pushing record. So if you have people who weren't able to join us today, we are recording, and we'll make the recording available. Usually takes 2 or 3 days before we kind of get all of that converted and posted online. But welcome to our monthly Becoming Baby Friendly in Oklahoma webinar. And this month, our topic is we're addressing 2 of the 10 steps, or portions of 2 of the 10 steps: maintaining lactation when separated, which is under step 5, and then medical indication for supplementation, which is part of step 6, the exclusive breastfeeding piece. So we have Carrie Hale, who is a board-certified lactation consultant and registered dietitian, and our clinical director for the Oklahoma Mother's Milk Bank, who will be co-presenting with me today. And she was having a little technical difficulties over there, but is online with us, and we'll be working through slides here. So let me make sure I can get my slides to work. There we go. So just, one disclosure that both Carrie and myself are at least partly employed by the nonprofit Oklahoma Mother's Milk Bank, and we will be talking a little bit about the milk bank towards the end of this presentation. So, Carrie, I'm going to turn it over to you now with the 3rd slide, the call to action slide.
Okay. Hello. Can you hear me okay?
Yes, I
okay.
can hear you.
All right. Well, thanks for letting me be a part of this. I'm Carrie, and starting now the call to action from, of course, the U.S. Surgeon General in 2011, where it kind of states one of the most highly effective preventative measures a mother can take to protect the health of her infant and herself is to breastfeed, which we probably all feel very strongly about. So we're going to kind of talk about that and dwell on that a little bit. Going into the next slide, slide 4, again, action number 12 identifies and addresses obstacles that we could get safe bank donor milk for fragile infants. So now really including supplementation with donor milk into the Surgeon General's call to action. So that's a good thing for babies, now that when we do have medical indication to supplement, that we can safely support and recommend the use of donor milk. And we will talk more about that at the end. The next slide is step 5, talking about maintaining lactation when we're separated from our infant. And you probably know all of these by heart, but show mothers how to breastfeed and how to maintain lactation even if they are separated from their infants is our baby-friendly hospital initiative step number 5. And so we're going to kind of talk about these things: how soon to start milk expression, importance of hand expression for colostrum, hands-on pumping, and skin-to-skin as soon as possible. Okay, so the next slide talks about pumping and hand expression. Needs to be started ideally within 4 to 6 hours of birth or separation from infant. And so here you see kind of a NICU baby. Of course, this baby is probably not going to be breastfeeding soon, so it's important to start that milk production, the expression of the milk as soon as possible. So 4 to 6 hours is ideal, but I mean ideal is right away. Not right away should necessarily lactation consultant be sent in to show a mom how to use the breast pump and this and that, but ideally even if the nurse could be just talking to the mom about it and showing mom how to do hand expression, and we'll go a little bit more into that in a minute. Okay. And the next slide. Of course, this is just a little cute saying, some people pump iron, I pump gold, which if you still feel strongly about breast milk, we do feel like it is liquid gold. So even that small drop of colostrum or milk could be precious for that baby in the NICU, and especially precious to that mom who's struggling with her baby being separated from her, and what do I do and what can I do to help my baby out. Just even a small drop of milk can be really motivating for a mother. Okay, so on to the next slide. Well, how does a mom pump or express for best results. Well, not with this. Not with this pump.
Like my
Becky can tell you more about that pump. I don't really want to practice with that pump by any means. But this old school pump is not ideal. The next slide is going to show you what would be ideal would be to start with hand expression. Hand expression into a little a little throwaway spoon, is what we use, a small little spoon, a small little medicine cup, a small little cup that we can even put the milk into, the colostrum into a syringe, but starting with hand expression as quick as possible. And that would be something, labor and delivery nurses or mother-baby nurses could easily show mom how to do, especially if it wasn't the ideal time for lactation to come in, or maybe lactation wasn't available, but having all of your nurses really, really well trained to show a mom and feel comfortable showing a mom how to do hand expression. If you ever have iPad capability or computer access, even kind of showing that there's a great video on hand expression that you've probably seen before, but even kind of showing mom and giving mom the confidence to be able to do hand expression on her own. All right. The next slide, practicing skin-to-skin kangaroo care. Of course, this first picture is actually me and my baby, which we were separated after birth. Baby unexpectedly went to the NICU, and I did what every lactation consultant does. I said, what can I do? What is going on? I can't believe this just happened. I guess I'll go ahead and pump. So pumped immediately after birth, and of course, not out of necessity for milk, but out of what in the world else am I going to do at this moment? But a time to explain to the mom how important it is to begin thinking about that milk and how great that milk is going to be for that baby, and to get started right away. And then we want to get into being able to be able to practice skin-to-skin, kangaroo care, to help obtain the milk supply, but to maintain milk supply more importantly. So really encouraging those moms and the staff to get mom and baby together as much as possible and let them know that kangaroo care is available and when it's going to be available, and that baby doesn't have to be discharging before they can do skin-to-skin, but how early and how soon that they're able to do skin-to-skin. Encouraging that for that mom and baby bonding, as well as all of the other benefits that go along with skin-to-skin care, but especially doing it before milk expression, before hand expression, or before pumping, to really shows that it's going to help increase that milk supply. Okay. Going on to the next slide, the other thing is really encouraging mom to relax when now we're setting her up with the pump. And of course, if she has a pump at home or a pump in her hospital room, I know it's not always ideal in the most relaxing situation, but giving her some tips and some useful things on not just how to pump, but other things she can do while pumping that's going to help her have more of a letdown and really release the milk. And these are going to be things like looking at pictures of the baby. So if she can take any pictures of video, if baby's separated from her or in the NICU, looking at those. Having a baby item, maybe it's a little towel or a little blanket, a little stuffed animal, a little outfit, a baby hat, anything small that she can keep with baby and then take back with her to be able to use and kind of put on her chest or hold on to be able to pump with. Listening to music, something soft and soothing, something relaxing, watching a video. Maybe she's watching a video about the baby, but maybe she's watching a video about pumping or milk expression, or something that you've been kind of talking to her about that you can kind of give her something to do at her next little pumping session that's going to just help and encourage her as well. A power nap, taking a little nap, a little bit of a rest, also can give mom that energy to feel like she can pump and complete pumping. Prop the feet up, of course, a comfy chair, a quiet area, which we know is a little bit hard in the hospital. If you have those little door tags that, or a little sign that you can put on mom's door that says, 10 or 15 minutes, give this mom a little bit of a break, or check in with the nurse so she can have that little bit of quiet times. Some moms can pump very easily, and some moms really need that concentration and relaxation to really empty the breast. Okay, the next slide is going to talk about the use of hands and hands-on pumping. Of course, another great video that we can recommend afterwards that shows hands-on pumping, but really these moms in this pictures have on a hands-free bra, which of course those are available, or mom could easily make one herself with just a sports bra and kind of cut the holes out in the middle for the flanges. But the hands-on pumping, really doing the breast compressions just like if we were breastfeeding baby, really doing the deep massage into the breast all the way around the breast and up under the arm is really going to help release a lot more milk than if we're just turning the pump on. So making sure the pump is on correctly and fitting well, but that we're really using those hands to be massaging down on those milk ducts gently to help release more milk. Okay, next slide. Painful pumping needs to be evaluated. So if any mom's telling you it's painful to pump, I always say, well, make sure that someone is observing you pump, whether it's the lactation consultant or the nurse or you know, if it's going to be a WIC clinic or a breastfeeding educator, we need to make sure that if a mom's complaining about pumping, that we can ensure what she's doing is correct and help her, because it should be really pain-free. If we're having pain with pumping, we're going to have a much lower milk supply. So the first things we would look at if mom is having the flanges fit properly, if it's the correct size. If mom's using a flange that's too small, it may irritate the nipple, may cause the nipple to really chafe or rub against the sides. If mom's using a flange that's too big, it's probably going to not give her enough stimulation and she's going to have a decrease in milk supply. If she's having, of course, pain, sometimes moms have those flanges off-centered. And then that's going to cause pain. It can also cause some nipple damage. And again, any pain is going to not release, allow mom to release enough hormones to have enough milk release. Ensure the suction is not set too strong. Some of these moms just want to get as much milk as they can, so they turn the suction and the speed full blast, and that's just too much all at once. In the beginning especially. And then also timing the pumping sessions. Have them set an alarm because sometimes moms will drift off to sleep, or sometimes moms won't be paying attention to what they're doing and they're telling us they're pumping for 30 or 40 minutes. And a lot of times that is just too long. And even though they might be pumping correctly, just a long length of time is also going to cause some nipple pain or nipple damage. And we want to make sure that's not happening. We'd rather have more efficient, quicker sessions that can be done frequently than infrequent, painful sessions where ultimately a mom's not going to be able to complete the pumping plan. Okay.
All right, my turn. So, hopefully we have enough milk for mom, but in the baby-friendly step 6, give infants no food or drink other than breast milk unless medically indicated, even when mom is directly nursing the baby. Of course, we're talking in this situation more specifically, say, babies in the room with mother on a mother-baby unit. And what are those common situations that, or what are the most common situations that may be encountered in the hospital setting where a supplementation may be indicated? So we're going to, and I think this is an area that it often is a great source of frustration for those who are working with the moms and babies and trying to increase your exclusive breastfeeding rate, trying to get your baby-friendly steps into place. And then, you know, what do we do with these babies when somebody thinks, you know, that they're not getting enough milk for whatever reason? So what are those medical indications? So I've tried to pull together in this presentation to kind of give you a good summary of what are the good resources out there, what are these organizations saying, and they're all fairly consistent. So it'll give you kind of a good body of evidence and recommendations that you can take to your baby-friendly task forces, your physicians, nursing leadership, and so forth to really advocate for this is, you know, this is why this should be in our policy. This is why baby-friendly wants this in your policy. This is not, you know, just making up what we think is best. This is actually based on evidence. So I didn't cite a lot of research, individual research studies, because all of these organizations, if they've had a publication or a policy statement or something, they have hundreds of references to support these recommendations. So I'm just going to kind of go through a few of these. So with the American Academy of Family Physicians, I know many of our hospitals may have family physicians who are seeing moms and babies, and so they have a number of policies and position statements related to breastfeeding. Their overall main breastfeeding policy is excellent. It's and they it's just been in the past year or so that they have updated it again, and so that's easily available on the internet. But they have a very brief kind of statement about the use of infant formula in breastfeeding infants. So I pulled a quote from that, and their recommendation, of course, is we should respect the decision of the mother who chooses to breastfeed exclusively by not routinely offering formula, water, or pacifiers unless there is a specific physician order. And I think you'll see this kind of comment repeated, and something too about not offering or not giving these other foods, supplements, etc., without a physician order. So something to take a look at in what your current practice is in your facility. In their main breastfeeding policy, they also made the statement that supplementation may be done with expressed mother's milk. Ideally, that would be our first choice. And second choice would be pasteurized human milk from a donor, or infant formula would be the third choice. So now here's some pertinent information from the American Academy of Pediatrics policy statement, which their most current one was released in 2012. They tend to update their policy statement about every 5 years. So breastfeeding and the use of human milk. So that's a really good document to be familiar with and utilize as one of your resources. So pulling some other recommendations from that, of course, we want to see 8 to 12 feedings every 24 hours. We want to make sure we're formally assessing and documenting breastfeedings by trained caregivers. And then here's the key point: give no supplements to breastfeeding newborn infants unless medically indicated, using standard evidence-based guidelines and then they went on to even say for the management of hyperbilirubinemia and hypoglycemia, with the assumption that those would be the most common situations that you're going to encounter on a mother-baby unit, not specifically, talking about a NICU baby. And then, of course, avoid routine pacifier use. And so I underlined, unless medically indicated, using standard evidence-based guidelines. So, and that's what Baby Friendly, as you'll see in a minute, also recommends, that you make sure you have a policy that's based on evidence-based guidelines, not Dr. Smith's personal opinion or preference of how to treat this particular or manage hypoglycemia in the breastfed baby, but what does the current evidence say as far as the management of that. Speaking of, so here's key quotes from the Baby Friendly Hospital Initiative as well. That breastfed infants will only be supplemented with a physician's order and only for clinical evidence of a medically justifiable reason. So that's a question we don't have the ability on here to do one of those little quick questions in the middle of the presentation, but I would certainly love to see, maybe some of you can note in the chat box if that's your facility's usual practice. Nothing's 100%, I know, but if your usual practice is that you have to have a physician's order to give something other than breast milk to a breastfeeding baby. And then, of course, Baby Friendly recommends, as you are developing and updating your infant feeding policy, that you make sure you have a list of current evidence-based medical indications that everyone is aware of. So, and then, of course, the Joint Commission in their perinatal care core measure set on exclusive breast milk feeding. They defined it as the newborn receiving only breast milk and nothing else, unless, medications or something of that nature. And they also went on to say that the use of donor breast milk is allowable. So those of you that are reporting the perinatal core measures to the Joint Commission as they are, doing chart audits and so forth, if your baby's on a mother-baby unit specifically were supplemented with donor breast milk, they would still count as an exclusively breastfed baby for the purpose of this core measure. All right, so what I really wanted to dig into a little bit more and give you more specifics is the Academy of Breastfeeding Medicine's clinical protocol on this topic. For those of you that are not familiar with ABM, the Academy of Breastfeeding Medicine, that is an all-physician organization, so it's a multidisciplinary group. You have OBGYNs, family physicians, pediatricians, infectious disease, and so forth that are members of that organization. And they actually receive funding from the U.S. Federal Maternal Child Health Service to develop a number of evidence-based clinical protocols related to breastfeeding. So, and they now, I just saw as I was kind of checking on this one again, that they are actually getting them all listed on the National Guidelines Clearinghouse website as well. So these are quality protocols. They're usually excellent. They try to keep them updated about every 5 years or so, and usually have a pretty lengthy list of references towards the end. So this particular one, I strongly recommend that your task force, your team that's working to implement baby-friendly practices, that you make use of that particular document as you address this issue. So anyway, this is what their website looks like, and you can go over here on the left-hand side where it says protocols and statements, and then I just kind of copied took a screenshot there, but as you get to clinical protocols, you scroll down and they have about 20, 25 different clinical protocols that are listed right now. A newer one they've done is one on the breastfeeding mother and substance abuse. So that's certainly an interesting one. And they have a variety of ones. They have them on mastitis, basic information, and then they have, the NICU graduate and so forth. So anyway, so from what ABM says, first they define what we're talking about. Supplementary feedings are really talking about anytime we're feeding a baby during the time period that baby should otherwise be exclusively breastfeeding. And so that's any foods given prior to 6 months, which for your purposes, of course, any of the babies that you're taking care of on a mother-baby unit would fall into this category, obviously. And then complementary feedings are feedings, what we consider age-appropriate, adding in age-appropriate foods after 6 months when it's recommended to start adding in those other, solids in particular to the older baby. So we're talking specifically about supplementary feedings given during that period of exclusive breastfeeding. Now, the ABM protocol first defines when supplementation is not indicated. They do say, we always want to make sure that we're properly evaluating and assessing what's going on with a particular mother and baby. But in general, these are some common situations where supplementation is not necessarily indicated. So your sleepy baby, and I know I often get asked, well, it says 8 to 12 feedings in 24 hours. What if they don't feed 8 times in that first 24 hours? Well, here's some guidance for you. If your baby's been kind of sleepy, if we've had less than 8 feedings in that first day or two, and we still have weight loss within normal limits and no other signs of illness, we don't have to rush to supplement a baby in that case. We may want to once again evaluate and see what can we do to encourage more feeding, such as get that sleepy baby stripped down, let's put that baby skin to skin, let's increase the amount of skin to skin contact over the next several hours and see if we don't see some change in our baby's behavior and more frequent feeds. So a healthy term, appropriate for gestational age infant, so not an LGA or SGA baby, but a healthy term AGA baby, and after 72 hours with a bilirubin that's less than 18. And so we may still have, some jaundice going on, but if we're otherwise, feeding, if our intake output is normal and our weight loss is still within normal limits, then we don't need to rush to supplement just because the bili is still up there a bit. And then, of course, fussy baby, constantly feeding baby, or the perception that the baby is constantly feeding, or a tired mother. So once again, in all of these cases, if something's going on that somebody thinks this baby needs to be supplemented, well, let's make sure that we've done a good assessment of the breastfeeding as well. So here we get into more specifics on what would be true medical indications for supplementation. Obviously, separation, anytime we have mother and baby apart from each other and we have to be able to feed the baby, though ideally, as Carrie went through milk expression, we would be using mother's milk. If the baby's not able to feed at the breast for some reason, and the baby may be in the room and not feeding very well. But of course, many of these we're going to see, really relate to a NICU baby. Of course, there's galactosemia, which is really a contraindication to breastfeeding. That baby's not going to be, getting breast milk at all. And then, of course, contraindicated maternal medications. So that's a fairly straightforward, I think, no arguments on that list. Now, these next two slides will talk about what the Academy of Breastfeeding Medicine calls possible indications. So once again, we may not have to supplement, but certainly it's certainly would be reasonable depending on our evaluation of the breastfeeding. So this slide, these are some common, or what they had listed as, infant situations. Anytime, of course, asymptomatic hypoglycemia unresolved by frequent breastfeeding. So that we've actually, had the baby nursing more and we still have the blood sugar dropping. So once again, as Carrie mentioned, hand expression and skin to skin. If we've had that baby skin to skin a lot with mom, say it's a diabetic mom, then, hopefully we prevent some of these low blood sugar episodes. But at any rate, if the baby's done a lot of skin to skin contact, then mom would be more easily able to hand express some colostrum that could be quickly fed to the baby in that situation. Hyperbilirubinemia, of course, they went into a bit more discussion here, kind of depending on, the age of the baby and the bili level and so forth. But in many cases, when the bilirubin goes up high enough and the baby's not feeding very well, or the baby's under phototherapy and not feeding well, then we are going to need to be feeding milk to the baby in some fashion. Certainly anytime we have poor milk transfer for whatever reason, we have evaluated a feeding and identified that the baby's not able to transfer milk effectively quite yet. Significant dehydration. And then, of course, these last two would be less likely on a mother-baby unit because most of your babies have gone home by now. But certainly meconium stools on day 5 is going to be a red flag that baby's not been feeding well. And, of course, then weight loss of 8 to 10% in combination with delayed lactogenesis too, when we get out to day 5 or later. So mom hasn't seen any signs of breast fullness and we're starting to approach that 10% weight loss, then that's certainly an indication for supplementation of that baby. So this slide then goes into more maternal related situations. So with this first bullet, delayed lactogenesis 2, approaching day 3 to 5 or later, and inadequate intake of the baby. And they specifically said related to the mother having Sheehan syndrome, where she's maybe had such severe blood loss that it's affected the pituitary gland, so she's not getting the oxytocin and prolactin release that she would normally. Of course, retain placental fragments. That's going to inhibit the increase in prolactin that we would normally see. And then fairly rarely would be true glandular insufficiency in a mother. So then, of course, anytime we've got a history of breast pathology or some kind of breast surgery, and mother seems to have, we've evaluated and appears to have poor milk production related to that. And then, of course, intolerable pain. And we've, tried a number of interventions, and she may need to, stop directly nursing the baby and go to some form of milk expression for a time period until such, that she can tolerate feedings, direct feedings again. I think if I've missed anything there. So, and Ingrid, can you see in the chat box if people type any questions in or anything? Will you let me know if there's a...
I see the chat box. I don't see any.
Okay. So, because I've got it minimized on my screen so it doesn't interfere with the slides, but let me know if there's a question that comes up, or if somebody wants to interrupt me anytime, absolutely, and ask a question. All right, then here's a biggie. How much do you supplement the healthy breastfed baby when there truly is a medical indication? So this is straight out of the ABM protocol, and this is also in the nice little booklet that the AAP and ACOG published together, which is the Breastfeeding Handbook for Physicians. They're going to have this very similar information. And what I particularly liked was that they made the point of saying that infants fed artificial milk ad lib, such as your baby who's being fed formula by bottle, typically have higher intakes than breastfed infants. So we need to be cognizant of that and recognize that something I've said for a long time is that we overfeed our formula feeding babies in these first few days. And they would also went on to say that while there's no definitive research, there have been a number of publications over the years about how much, newborns eat in the first few days, but they, certainly strongly suggest that the supplements should reflect the normal amounts of colostrum, the size of the baby's stomach, the age and size of the baby as well. So, so here you can see first 24 hours where we typically say, 5 mils of feed or teaspoon of feeding. The first couple of the second day is going to roughly double that, so maybe 2 teaspoons of feeding, and over the around the third day approaching 15 mils, which is a half an ounce, so per feeding. All right, then of course once we've identified we have a medical need to supplement, we've identified what we're going to supplement with. Maybe we have milk from mom that we're going to supplement with. And then, of course, the question is, how are we going to give that supplemental feeding? So that could be another whole presentation talking about alternative feeding methods and pros and cons and evidence to support them. But in general, and this is something that I also cover a bit more in the Making Breastfeeding Easier classes that I do for staff around the state. But most of the alternative feeding methods have very little evidence or research to support their use, whether it's their safety or is this an effective method to use. If I supplement by this particular method, is my baby more likely to still be breastfeeding, in some future time period? So, but the one that Baby Friendly strongly recommends is cup feeding because that has the most evidence to support it. It's actually, there's been enough studies on cup feeding, both in the United States with term, preterm, late preterm babies, and in other countries, that there have been at least 2 Cochrane reviews as well, summarizing, the information from those studies. So enough said on that topic. Now, I also want to make sure that y'all are aware with the ABM's protocol on supplementation, they have a lovely appendix. I just kind of copied the first portion of it. But this is at the end of the protocol. So after you've gone through the 125 references at the end, then they have this appendix, which gives the rationale for and kind of some scripting, things that you can say for all those requests for supplementation that are not medically indicated, and kind of also what I think of as mom requests. What do we do when the mom's worried that she doesn't have enough milk and she thinks she needs to supplement? So here's some good, recommendation and kind of different things, that you can say. So this is, and so this is like a couple of pages. So this is just the first couple of little bullet points that are on that list. So that's a really great resource to use, especially as you're maybe developing some staff education and staff training and so forth, because I know this can be a very frustrating topic as well when you get your nursing staff educated and excited about helping moms and babies breastfeed, and then they know the baby's latching well and they know they're doing great, and then the family's asking for formula, and that can be very frustrating. So hopefully this will be another resource to help with that. Now, I know the hospitals that we have on today are in different stages of your baby-friendly journey, and so you may not see some of the impact that you will later on, but certainly the goal with baby-friendly and putting all of the 10 steps solidly into places that will reduce the need for supplementation. Not eliminate it completely, obviously, but when I see, oh yay, the question popped up. The appendix is at the end of the Academy of Breastfeeding Medicine's protocol on supplementation, the one that I was kind of just going through some of the information from, and that's available on their website. And we can send that out as well. In fact, Ingrid, that's probably, when you send out the PDF of the slides or the link or whatever, you could include the ABM protocol. That's readily available on the internet as well. But anyway, as you get the 10 steps really solidly into place, I think you'll see moms and babies are going to be breastfeeding more successfully. They're not going to have painful latch. If they're rooming in, they're feeding on cue and so forth. I think you'll see that you have fewer situations where there's some kind of, consideration of supplementation. So, all right, well, this last section, and Carrie, you pipe in here anytime. We just wanted to kind of also talk about, because in all of those recommendations, they also stated that pasteurized donor milk can be used as a supplement, not only in the NICU for the preterm babies, but also to help the term baby who has a medical reason to be supplemented, help that baby, continue exclusive breastfeeding as well. So a little bit about doing that, or, how do you manage pasteurized donor milk on a mother-baby unit. So a little bit from the Oklahoma Mother's Milk Bank. And as many of you may know, that our milk bank was the 13th, 13th milk bank to Habana Milk Bank. Whoops, hello? Is everybody still there? Ingrid, can you still hear me?
Yes.
Okay. Not sure what that beep was about. Anyway, so Oklahoma Mother's Milk Bank was the 13th milk bank in the country when it opened. There are now 15 nonprofit milk banks in the United States, and our milk bank and all of the Habana milk banks go through an accreditation process. Actually, we get accredited annually, and that's coming up next month. We'll have our third accreditation with Habana. and where they come out and actually really watch our whole pasteurization process, and they review all of our documents and policies and procedures and so forth, and make sure that we're following, the current best practices in the milk banking industry. So we're very proud of that. And this is Habana's website, the Human Milk Banking Association of North America, which oversees all the nonprofit milk banks. So you can certainly get a lot of other information from their website as well as our own. But when we talk about using pasteurized donor milk on a mother-baby unit, you're going to, of course, need something to store the milk in, since it's going to come frozen. Now, I'm not saying you're going to store it in a little cube fridge with Powerade and yogurt and so forth, but just to give you an idea of, you don't have to have a giant deep freeze. You can use just a little cube-sized freezer, because, of course, we're not talking large volumes of milk. We're not talking about, this is something maybe that's going to be needed every single day on your unit, depending on how many babies that you deliver. But in many cases, it may be, once a week or once or twice a week kind of situation. So we do want the pasteurized milk, if you're stocking that on your mother baby unit, that it is separated from, say, if you have a little fridge or freezer, that you're keeping maybe expressed milk in from some of your mothers, that you have it separated. And obviously it's could go in the little freezer compartment in a freezer of this size. If you have, a larger fridge freezer, just that you make sure that it's kept in its own separate little bin and identified as pasteurized donor milk. Of course, the temperature has to be, tracked daily, and just as you would with anything else in a hospital setting. You don't have to stock a lot of donor milk, but you don't want to wait to order until you have a baby that needs it, because that means you need it in the next hour very quickly. So it's just something that you want to have on hand. So our milk bank can provide pasteurized donor milk that has, a long expiration date. It could be 6 months or longer, especially when we know it's going to go to a smaller unit that's going to not, go through their stock as quickly, say, as a level 3 NICU would. So we can certainly take a look at that. And then you're going to want to make sure that you address documentation so let's see. So Joni says milk expressed. Whoops. Ingrid, can you read that to me? I missed it. Joni had a question there.
I can't see it.
Oh, you can't see it now? Okay, let me pause for just a second. It popped up there, and then I didn't read it fast enough. So milk expressed on the unit and the pasteurized milk can be in the same freezer, just in different bins. Yes, you want to keep them just as if you had in your large NICU, you may have one huge deep freezer that all your human milk is stored in. And your mothers who are expressing milk, you have milk for baby Johnson here and baby Garcia here. And then over here in a completely separate bin is your pasteurized donor milk that some of your babies may be getting. So yes. But you're going to want to, on a mother baby unit in particular, you're going to make sure that you have some means to document that pasteurized donor milk was fed for that feeding at 10 o'clock. And that there was a medical, why this baby got this supplemental feeding, of course, but that what it was, not just that if the baby got supplemented and you don't indicate donor milk, then the common assumption, of course, is that the baby got formula. So if you don't document the donor milk, you have no way of knowing that the baby got that. And then also, ideally, you would be documenting the batch number, and I'll show you that. This is actually what a bottle of pasteurized donor milk from our milk bank would look like. OMMB is Oklahoma Mothers Milk Bank, and this is the batch number, kind of like a lot number, if you will. Here's your calories, here's your expiration date, all the way to October. And we currently provide milk in these little 100 ml bottles, so that's 3 1/3 ounces roughly, and then the protein content, which typically most of this information you don't need on a mother-baby unit, but you do particularly need the batch number and, of course, the expiration date. So for our accreditation purposes and safety protocols, our milk bank has to be able to track, say if we did a recall of a particular batch for some reason, we have to be able to contact every place that milk from that batch went to. And then we have to be able to trace it all the way back actually to what donor mother's milk was in that particular batch as well. So, and just in handling donor milk, because of course it's going to be frozen, and you're like, well, if I have a 100 ml bottle and I only need 10 mils to feed my baby with low blood sugar, what do I do with the rest of this? Well, you can thaw your milk just enough to draw off a small amount, and if you still have ice crystals in the milk, that can actually be refrozen. If it's depending on the situation, say if it's hyperbilirubinemia, where that baby actually may need more than one feeding, may need, several supplemental feedings that day, you're probably going to want to allocate, that particular bottle for that baby and just, go through that stock. But if it's low blood sugar and you just need 1 or 2 feedings, then that milk could be, you could pull out of that bottle and save that milk to utilize for another baby. And some newer research that just came out at the end of last year in the Journal of Human Lactation, where one of the milk banks actually did a nice little study, because we all suspect that our current recommendation of once you thaw pasteurized donor milk that you have to use it within 24 hours. We've all long, said that that's extremely conservative, and we know nothing's growing in it. And here's the study that showed actually that it actually didn't grow anything in most of the samples for as long as 9 days in the refrigerator. So we're still being very conservative here, but the title of the article, said it's still completely sterile, as easily at 4 days out when stored. So and so just to let y'all know as well, that with our Oklahoma Mother's Milk Bank, which has been in operation just a little less than 2 years, that the first goal was to be able to pasteurize enough volume of milk to meet the needs of all of our level 3 NICUs in the state, which we are currently doing. And then our next goal was to, as I've highlighted in yellow here, that we wanted to be able to provide milk to our smaller special care type nurseries and mother baby units, so that we're addressing the needs of any baby in the hospital that has a medical need for supplementation other than mother's milk. And then, of course, we're continuing to work on outpatient as a service as well. So, and I wanted to just make sure we, excuse me, just received a grant from the Sarkees Foundation. So I have to say a big shout out to Sarkees. And this purpose of that grant is to actually help us expand our courier service so that we can be more, easily delivering milk to more hospitals and not rely so much on FedEx. So we'll be kind of launching that as well. Anyway, this is the last slide here to kind of end with, and just those of you that are maybe not currently, providing donor milk, but want to look into stocking a little bit for those situations on your mother baby unit, you can go to the website, okmilkbank.org. You can call the milk bank at 297-LOVE, or you can certainly email Carrie or myself at okmilkbank.org. So without any further comment, I will open up if there's other questions. And let me just kind of double check the chat box here as well. So do you have to have written consent from the mother to use donor milk? It's not, I think that's a great question, and that's a practice that varies from hospital to hospital. Some hospitals require a consent form, and we can certainly send you a sample consent that you could modify. Of course, most hospitals don't require a consent to give formula, so there's to me still a little bit of a double standard there. But not every hospital requires a consent form, so that's certainly something you'll have to take up with your risk management and legal. I can say that in, gosh, all the years of current modern day milk banking with the donor screening and pasteurization process, that there hasn't been a single documented case of any adverse outcome of a baby who was fed pasteurized donor milk, and and having the milk be contaminated or something. So definitely a very, very safe product. Plenty of evidence, publications that have been done on pasteurized donor milk from our nonprofit milk banks. So other questions that people have, if you're on the phone, or you can certainly ask a question, or you can type something else in the chat box. Maybe I'll ask a question. Do we have anybody on the phone today that has used some donor milk on your mother-baby unit specifically? Not necessarily. I know some of you are, like St. John's is on the phone, and I know they use donor milk in their NICU.
We have an OU.
Who's that? Is that Jamie?
Yeah.
Okay. Hey, Jamie.
Hey.
Anything you would add? Any challenges y'all have encountered in using donor milk on your mother-baby unit?
Not really. We're working on guidelines for use of donor milk, just with some of these medical indications that you mentioned today, just so the nurses have better guidelines and can kind of have a little more autonomy and not have to go through lactation when they have a mom that needs to use them as supplementation. So otherwise, it's gone well.
Oh, good, good. All right, anyone else? Let's see, while, kind of seeing if we have any other questions, just I'll do a couple of quick announcements. And Ingrid, remind me what our next webinar topic is. As y'all hopefully know, that we are scheduling these on the same Wednesday, the second Wednesday of each month at 3 o'clock, and trying to kind of correlate whatever the topic is with one of the 10 steps. And the previous ones we've done so far this year are posted on the website, and you can see the topics that are currently scheduled. So this Friday is the 15th annual WIC Breastfeeding Symposium. So that's a free conference. There's an excellent agenda of speakers this year, and actually doing a couple of the panel sessions with different organizations representing, different resources in the community, but also some really good professional speakers that are coming this year. And so that's Friday, and you can still register for that at, Ingrid, is it www.okwic.com?
Yes, OKWIC. I've got it on the website.
And that's up, yeah, that's right.
OKWIC.com, and it's also on our website under training or events.
Oh, good. Okay, that's right. So, yeah. So
and our next webinar is, it's kind of a general question and answer period, and then we're also going to discuss a little bit about World Breastfeeding Week, which is August 1st through the 7th.
Yes, and then later on in August, probably kind of the next major breastfeeding conference, if you will, is the Oklahoma Lactation Consultant Association's annual conference, which is like the last Friday in August. That's on our website as well. Okay, so I see another question. Has anyone used donor milk for mothers that ask for a bottle because they feel the infant is not getting adequate volume? So that's a great question, and I know Jamie can probably speak to that as well, but I think we would really try to avoid using donor milk in that case, because that's a situation where the baby doesn't need to be supplemented, at all. And we might what I would do is assess once again, why does the mother feel the baby's not getting fed? How can we educate the mother and reassure her? And then, reiterate that we have donor milk available if there's a medical reason, and we actually want to prioritize the donor milk for those babies that have a medical need to be supplemented. And the good news is her baby doesn't have a medical need to be supplemented. And here's how we know that. So Jamie, I don't know if you're still on the phone, if you wanted to add anything to that.
No, that's really it. Also, it's a good time to go over hand expression with mom so that she can see that she does have milk and that she can use some of her milk if she wanted to hand express and spoon feed some. If that makes her feel more comfortable that the baby's getting more, she can breastfeed and do her own hand expression and spoon feeding. So.
And I will say too, and just remembering, from my experience at OU, and I hope this is, not so much of an issue anymore, Jamie, but if you're trying to make the case to make donor milk available on your mother-baby unit, that you reassure your nursing leadership, your hospital administration, or whatever, that you're not going to be giving donor milk to moms who don't want to breastfeed. Where they start picturing that we're just going to, start spending all this money to feed all these babies, that the donor milk is to be prioritized for mothers who are trying to exclusively breastfeed and have a medical need for supplementation. So that's going to be a, very limited group. And as you work on your baby-friendly practices and get those implemented more fully, you will reduce the need for any supplementation. So that's the goal overall. All right. Well, I think our time is just about up. So thanks to everybody for joining us today, and give us feedback as always if this was a helpful topic, and then also give us feedback on other topics that you would like to see addressed on these webinars. So we can make sure that this is a helpful experience for y'all. I'm going to stop the recording and